All right, good afternoon, everybody. It is Thursday, December 10th, 11th meeting out of 14. So we got 3 more next week, Monday, Tuesday, and Wednesday. I won't be doing a meeting on next Thursday because it is the last day of the semester, and we got grading to do and things like that. So, and it's also the last day of class because we're off for 3 weeks. Hoo-ah. So that's a good thing. So today what we're going to do is we're going to go over the muscles that perform each of the movements. Now, in Zoom meeting number 3, we went over terminology and planes, and then we went over range of motion. And we went over all the motions that are performed at the joints. Like at the neck, we talked about cervical flexion and extension. At the shoulder, we spoke about shoulder flexion and extension, shoulder abduction and adduction, shoulder internal and external rotation. So what I'm going to do is I'm going to go through the joints and the muscles that perform those motions, and I'm going to put them into categories. So like we'll be starting off with ankle adduction. I'm going to describe the motion and then tell you all the muscles that perform that action. Now, I also have a handout that I'll be giving you guys probably the Thursday of week 1, because that's when we'll be starting the muscles actually. So I'll be giving you this, and hopefully that with the innervations will help you guys out a lot with your studying. So
is the bone practical 2 weeks after it starts though?
Yeah, the bone practical will be on the Thursday of week number 2. Thursday of week 2 will be the bone comp, and the Wednesday of week 4 will be the muscle practical. So, like I said, the way the bone practical is going to work, there's going to be a bone on the table. You're going to tell me that bone. That's all it is. It's just going to be identifying what the bone is. On my exams, like starting on the second quiz on day 2, you'll have the information from the intro class, and I'm going to be asking you guys questions on the bones, on the landmarks of the bones. And because I'm doing these classes in this way, I'm actually going to be able to talk about muscles with the bones themselves. So when I'm going over the bones, I'm going to also talk about the muscles that attach to those bones. This way I can actually use it on exams. I can start right off with them. So the muscle practical will be the same thing. I'll either show you a picture of a biceps brachii, and you'll tell me that it's the biceps brachii, or I'll show you a model, and I'd say, what is this muscle? And you would tell me what the muscle is. So again, the practicals are just identification. It's on the quizzes where you will be tested on the bony landmarks and on origin, insertion, actions, and innervations. Answer that question?
Yes.
Fantastic. All right, let me see if I can actually pull up this sheet so people can see it. Yeah, there it is. Fantastic. All right. So Ashley, what you're going to see is you'll see something seen as movements. Give me 1 second. Let me scroll this all the way back up. So you'll see movements there. That's where we're going to start with. So like I said, this will be a lot like yesterday, probably about an hour. probably not much more than that. Really quick, let me give the schedule for next week real quick. I'm going to go through the bones on Monday. I'm going to try to actually start the muscles again on Monday also. So the bones, I'm going to go through them. I'm going to go through the landmarks. I'm going to talk about the muscles that attach to them. On Tuesday will be all about muscles. All right, we'll go through origins and insertions, and we'll kind of go through the muscles that will be on the practical. I'll try to finish them up on Wednesday, and then on Wednesday, I also want to go over the syllabus for the intro class to kind of give you guys an idea of how the schedule is going to work. So that's the schedule for next week. All right, so we're going to start at the ankle. Again, I also shortened some muscles up. So when you guys are watching the video and I say what those muscles are, I would write it down. I would write them down. So this way you can take some notes here. So ankle adduction. So remember, ankle adduction is where the heel is touching the floor and you're moving your foot inwards. The heel stays touching the floor and you're moving your foot inwards. Well, the three muscles that perform ankle adduction are the Tibialis Posterior, the Flexor Hallucis Longus, and the Flexor Digitorum Longus. Now, Tibialis Posterior comes from the back side. So, but it's one of its major attachment points is on the median portion of the foot, on the navicular tuberosity. And it's because of that insertion that it brings the foot inwards. Flexor hallucis longus is a muscle that attaches to the big toe. So being the big toe is on the medial side, hence it brings the foot inwards. Flexor digitorum longus goes to the bottom of the foot and helps flex the toes and flexes the foot, the ankle also, but it also does adduction. It brings the foot inwards. Now, there is something special about these three muscles, tibialis posterior, flexor hallucis longus, and flexor digitorum longus. These three muscles together are known as the Tom, Dick, and Harry muscles. And these are important because they actually go they're on the medial side and they go around the medial malleolus and they attach at different places. So the name of each of these muscles is part of the quote, Tom, Dick, and Harry muscles. So the Tom in this case is the tibialis posterior. And like I said, it inserts onto the navicular tuberosity. And that's a bone that you will look at when you guys get into class. The D muscle, or the dick, is the flexor digitorum longus. Now, flexor digitorum longus goes to digits 2 through 5 on the bottom of the foot. So those muscles go on the bottom and pull the toes into flexion. Okay, pulls the toes into flexion. And finally, the H muscle, or the Harry muscle, is the flexor hallucis longus. And again, hallucis means big toe. Remember, pollicis means the thumb. Flexor hallucis longus comes around the medial malleolus and attaches onto the big toe. Again, it's on the medial side, making the foot go inwards. So the adductors of the foot, again, tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And again, these are the Tom, Dick, and Harry muscles. Ankle dorsiflexion. Right? Ankle dorsiflexion is where the toes come up towards the tibia. Like when you're walking and your foot is in the air, you bring your toes up in order to not slide your toes against the floor. So ankle dorsiflexion is bringing your toes towards the tibia. Ankle plantar flexion is bringing your toes towards the ground. So the muscles that perform ankle dorsiflexion is the tibialis anterior. So the tibialis anterior starts on the anterior side of the tibia and a part of the fibula. It actually goes across the medial side, and tibialis anterior actually attaches to the first metatarsal, also the medial cuneiform. So it's actually on the medial side. So you will actually see this muscle again as an inverter also. A couple of the extensors help with dorsiflexion of the ankle. Now remember, I said the flexors are on the bottom of the foot. The extensors are on the top of the foot. So if you think about those muscles pulling and coming together, it's going to bring the foot upwards. Hence, extensor hallucis longus. Again, hallucis longus goes to the big toe, so it extends the big toe. And extensor digitorum longus extends the digits, but also dorsiflexes the foot. Finally, we have Fibularis tertius. Now, Fibularis tertius, like I said, you might hear it again as Peroneus tertius, but Fibularis tertius crosses in the front of the foot, all right, and then attaches to the fifth metatarsal. This muscle also helps with dorsiflexion of the ankle. So the important muscle in dorsiflexion is the anterior tib, or the tibialis anterior. That muscle is the key muscle. When that muscle is weak, what usually happens, we have something known as foot drop, where if that dorsiflex, the anterior tib is weak, it can't bring the toes up. If it's weak, the toes will just drop, hence foot drop. And that's why we have to wear certain types of prosthetics in order to keep our feet in a neutral position. Ankle eversion is when the whole lateral side of the foot moves outwards. Ankle eversion is bringing the whole lateral foot outwards, and ankle inversion is bringing the whole medial foot inwards. Okay, so ankle eversion and inversion. So if you have eversion and the foot is going outwards, a lot of these muscles are going to be on the lateral side. Okay, so let's take a look at the everters. Extensor digitorum longus, all right, is one of the everters. Fibularis tertius is on the fifth metatarsal on the outside, makes it an everter. Fibularis longus, all right, because of its position on the lateral side, makes it an everter. And Fibularis brevis, again, you will hear Fibularis and Peroneus correlated with each other. But as long as you know that, Peroneus equals Fibularis, use Fibularis, because Fibularis is telling you that it's coming from the fibula bone. The fibula bone is on the lateral side. Hence, those three muscles, tertius, longus, and brevis, are all everters of the foot, bringing the lateral portion of the foot outwards. The next movement is ankle inversion. Again, like I said, it's where the middle portion, the medial foot goes inwards. again, you need to picture the muscles and how these muscles are going to work. Those muscles have to be on the medial side. They have to end up on the medial side. So you'll notice there's no fibularis muscle here on the inverters, because those muscles end up on the lateral side. So the inverters have to be on the medial side in order to move the foot inverted. So the tibialis anterior, remember I said the tibialis anterior goes to the first metatarsal, right? So it's on the medial side. Tibialis posterior, remember I said tibialis posterior inserts into the navicular bone, and the navicular bone is on the medial side. That's why the navicular is an inverter. Flexor hallucis longus. Again, hallucis means big toe. The big toe is on the medial side, hence flexor hallucis longus. All right, and flexor digitorum longus has its insertions on the bottom of the foot on digits 2 through 5. So 2 and 3 are very, very strong and creates a strong inversion. So those 4 muscles are the ankle inverters. And another thing that you can call with the inverters, the Tom, Dick, and Harry muscles, tibialis posterior, flexor hallucis longus, and digitorum longus are all part of that. So, you know, the Tom, Dick, and Harry muscles are for all the ankle adductors, and 3 out of the 4 ankle inverters. Because again, like I said, it comes around the medial malleolus and it attaches medially. Hence, they're going to invert the foot. Ankle plantar flexion is the movement of the foot going downwards. When we push off on the foot, all right, when we bring the heel up, we're pushing down on the ground. We're plantar flexing. Well, we have a lot of muscles that actually perform this action, and a lot of our big muscles perform it. Fibularis longus and brevis both do it. Both do plantar flexion. The two main muscles that perform plantar flexion of the ankle is the gastrocnemius and the soleus muscles. All right, gastrocnemius is superior or superficial, and the soleus is deep to the gastrocnemius. Okay, so those 2 muscles are found in the calf. The plantaris muscle is not a major plantar flexor because it's so thin. Remember, this muscle was, it's a very small muscle, but it has that very long tendon that attaches into the Achilles tendon and into the calcaneus. Not a major mover of plantar flexor, okay? But tibialis posterior definitely is. And again, you're going to see the Tom, Dick, and Harry muscles here also. All right, so tibialis posterior, flexor hallucis longus, and flexor digitorum longus. So if you know that gastroc and soleus are the major plantar flexors, and you know the Tom, Dick, and Harry muscles are plantar flexors, then you know 5 of the plantar flexors. That's really all you're going to need. All right, that's really all you're going to need for the plantar flexors. All right, so again, plantar flexors pushing the toes downwards into the ground. Now, there's a couple of special movements that combine 3 of the movements, and I need you to know them because the national exam likes to pick on these 2 movements because they're kind of hard, okay? Again, I spoke about an acronym that I made up for myself. There was a cartoon. I know I spoke about it, the Sherman and Peabody cartoon. It was a brilliant dog adopted a boy, and Sherman was the boy and Mr. Peabody was the dog. And I remembered it as a kid, and I kind of used it to make an acronym. So ankle pronation, all right? So when the ankle pronates, it does three motions. It does Peabody. It does plantar flexion, the P. It does eversion, the E. And it does abduction, the ABD. So pronation is a combination movement of the ankle of plantar flexion, eversion, and abduction. As long as I know pronation of the ankle, supination of the ankle is the complete opposite of it. Supination of the ankle is dorsiflexion of the ankle, inversion of the ankle, and adduction of the ankle. So I don't care how you figure it out and how you guys want to study it. You can use my acronym. You don't have to. It's up to you. There's no copyright on it. But find a way to recall it, because questions that involve ankle pronation and supination are high-level questions. All right. The exam is not worth the same all the way through. There are questions that are harder, high level, and there are questions that are not as high, low level questions. Well, you get those higher level questions, you're going to get more points. And these two concepts of ankle pronation and ankle supination lead to higher point questions. So again, ankle pronation is a combination movement of plantar flexion, eversion, and abduction of the ankle, while ankle supination is ankle dorsiflexion, ankle inversion, and ankle adduction. Okay, so that's everything at the ankle. At the fingers, well, the fingers, we have flexion and extension at the fingers. The digits. They very, very rarely ask you questions about the toe flexors and extensors, but they ask you about the fingers. All right, they will ask you about the fingers. Now remember, I said when we spoke about the muscles that anything that has a carpi in it, like flexor carpi radialis, never goes to the fingers. They have no action at the fingers. So you'll notice on these two lists of the extensors and the flexors, there's no carpi. You'll see a lot of names with digits in it. All right. So the names with digits, move the digits, move the fingers. All right. So there are three of them on each. The muscles that extend the finger. So these are muscles that are on the top of the hand. Extensor digitorum. Digitorum goes 2 through 5. Extensor indices extends the index finger, and extensor digiti minimi extends the pinky. So extensor digitorum extends 2 through 5, 2, 3, 4, and 5. Extends those fingers. Extensor indices, just digit number 2, the index finger, and extensor digiti minimi extends only the pinky. The flexors are on the anterior side. Okay. The flexors are, and I spoke about them at length also because their insertion points are so important. Just like I talked about pronation, supination being high-level questions. Well, information on Flexor Digitorum Profundus and Flexor Digitorum Superficialis are very high-level questions because students forget. There's so much information. Like I said, I'm going to give you guys a handout that's approximately 30 pages long on everything we do as physical therapist assistants. There's a lot of info. So you forget things. But I don't want you to forget these. I'm already pushing it, and you guys aren't even in class. So the finger flexors that create this movement here. Well, we have Flexor Digitorum Superficialis. Flexor Digitorum Superficialis only goes to the PIP. It does not flex the DIP. The DIP is the joint at the end. It goes to the joint in the middle. So the middle part of this finger is where superficialis inserts, and it does this motion. The second flexor of the digit is Flexor Digitorum Profundus. Profundus does go to the DIP. So it is Flexor Digitorum Profundus, the FDP, that flexes the small joint at the end of the index finger, digit number 3, digit number 4, and digit number 5. So again, Flexor Digitorum Profundus inserts into the DIP and is the only one that flexes the DIP. Flexor Digitorum Superficialis inserts into the PIP, and it does not flex the DIP. The final flexor of the digits is the Flexor Pollicis Longus. Again, pollicis means thumb, so it is the main flexor of the thumb. So the movement that slides the thumb across the fingers. All right. So we're going to go to the elbows now. Remember with the elbow, we really only have 2 moves. This is a hinge joint, just like a door opens and closes. Well, the elbow only flexes and extends. That's all the elbow does. Okay, so not a lot of muscles perform it, but important muscles that you need to know. The elbow extensors, there are 2 of them. They are the triceps brachii and the anconeus. Remember that anconeus was the small muscle, all right? That's at the elbow. It has no action at the shoulder. So triceps brachii, anconeus for elbow extensors. The elbow flexors is a muscle group that I created a nice simple acronym for it. Elbow flexors are BBB: biceps brachii, brachioradialis, and brachialis. Those are the 3 muscles that perform elbow flexion. Brachialis is the workhorse, is the muscle that the nervous system picks like all the time to perform elbow flexion. Now, if there's a elbow flexion and a supination, like if you're going to screw in a screw with a screwdriver, well, the biceps brachii does supination also of the forearm. So it would be the biceps that the nervous system would pick to do that action because it would be definitely energy efficient. So again, the elbow flexors, think BBB, biceps brachii, brachioradialis, and the brachialis muscle. Forearm pronation and supination. Remember, understand that I said the forearm is where this movement is occurring. The movement does not occur at the wrist. The wrist just goes for the ride. It's the wrist that you follow. Palms down is pronation. Palms up is supination. Supination, you want to hold a bowl of soup. The only way you can hold a bowl of soup is with your palms up. Can't hold it with your hand pronated. Okay? So forearm supination and pronation. And also remember that the only bone that moves in the forearm is the radius bone. So every one of these muscles insert into the radius. All four of these muscles insert into the radius because it is only the radius that moves. Remember, we spoke about when your forearm is supinated, the radius and the ulna are parallel to each other. When you pronate, the radius crosses over the ulna, creating an X shape. Excuse me for a second. Need a drink? Creating an X shape. So again, it's the radius that moves, which means that the insertion of each of these muscles is on the radius. So the pronators of the forearm are Pronator Teres. Right? Pronator Teres comes from the medial epicondyle. Remember what I spoke about with the medial epicondyle is most of the flexors of the forearm and wrist and fingers come from the medial epicondyle. And Pronator Teres inserts into the radius bone, to the proximal radius. All right, so it performs pronation. The other muscle, so that's a proximal muscle. The other muscle that pronates is the Pronator Quadratus. Pronator Quadratus is more distal. All right, its origin is on the ulna, and it goes over and it inserts on the radius. It's a square-looking bone, square-looking muscle, hence the name quadratus. Okay, Pronator Quadratus. The supinators of the forearm, well, the biceps brachii is a major supinator. All right, it's a major supinator. Excuse me. But it's not the most important supinator. The supinator muscle itself is the muscle that is most important. It's the supinator that's the first to respond from the nervous system to perform a task. So when we're talking about elbow flexors, it's the brachialis. When we're talking about the supinators, it's the supinator muscle that is the main mover in supination. Okay, and again, so we said the Pronator Teres comes from the medial epicondyle, which is the common flexor tendon. The supinator comes from the lateral epicondyle, which is the common extensor tendon. It also then inserts onto the radius. Remember, the biceps brachii comes from the supraglenoid tubercle and the coracoid process, and it inserts onto the radius at the radial tuberosity. So again, all four of those muscles for pronation and supination insert onto the radius bone. We'll head down to the lower extremity for a little bit. We'll do some of these large muscles at the hip. The hip abductors, remember abduction is the bringing out of a body part. All right, the leg goes out to the side. Abduction, away from the body. Well, there are three muscles that perform that. Two of the glutes, glute medius and glute minimus, and the small TFL or tensor fascia lata. That tensor fascia lata is directly on the lateral side. Remember, it inserts into the iliotibial band, so it's right on the lateral side. So again, the three main hip flexors, glute medius and minimus, and the TFL. The hip adductors are the muscles that bring the leg back towards the body after the leg has been abducted. Pectineus is a muscle that does a deduction of the hip, but it's not a major mover of it. I just put it on the list. Not a muscle that I really want you to worry about. The muscles I do want you to know are the rest of them. First of all, if you're going to do hip adduction, that means the hip adductors perform it. There are 3 adductors. You need to know them. Adductor Magnus, Adductor Brevis, Adductor Longus. They each do hip adduction. The other muscle that does it is the gracilis muscle. Remember that gracilis muscle is that thin muscle that comes from the pubic area, and it attaches into the pes anserine, that area located on the tibia. It's on the anterior proximal medial portion of the tibia, right next to the tibial tuberosity. And that pes anserine is an insertion point for 3 muscles: the gracilis, the sartorius, and the semitendinosus. Very important. So for the adductors, know the 3 adductors: longus, brevis, and magnus, and also gracilis. Those are the important muscles you'll need to know. Hip extensors. So if you're standing up, you bring the whole leg behind you. That is hip extension. Or if you're lying down in the prone position on your tummy, you're bringing the leg upwards against gravity. Well, the major hip extensor of the body is the gluteus maximus. Glute max is the major hip extensor. Major hip extensor. Now, remember I said yesterday when we talked about the lower extremity muscles that the hamstrings all have origins at the ischial tuberosity, which means it crosses over the hip joint. Well, all the hamstring muscles together flex the knee, but because it's a 2-joint muscle, those 3 muscles also extend the hip. So semimembranosus, semitendinosus, and biceps femoris perform hip extension. Let's kind of go through those hamstrings again. 2 of those muscles are on the medial side of the leg, and 1 of them is on the lateral side. The semitendinosus is one of the muscles on the medial side. Semitendinosus is the most superficial muscle of the 2 medial hamstring muscles. And the semitendinosus is another muscle that attaches and has its insertion into the pes anserine. Remember the gracilis, sartorius, and semitendinosus. The second medial hamstring is the semimembranosus. Semimembranosus is deep to semitendinosus. It's very hard to palpate. You really have a trouble feeling that tendon. It's somebody that has a little thickness to them like me. If you're thin, there's a good chance we'll be able to palpate the semimembranosus. The third hamstring muscle is the biceps femoris. Biceps femoris is on the lateral side of the body. It is a tendon that you will be able to palpate. The final extensor is the very large adductor magnus. Adductor magnus is a vast muscle, a large muscle that attaches into the back of the leg, into the linea aspera. You remember that ridge area on the posterior femur. Well, because that muscle is so large, it helps pick up the leg and pull it into extension. So the hip extensors, The main one is the gluteus maximus. You know the hamstrings all do hip extension, so you got the other three. Adductor magnus is sometimes the one that's left out, but remember, big muscle that attaches to the back of the leg, the back of the femur. So it's a muscle that when it contracts, it picks the leg up. So those are the 5 hip extensors that you need to know. The hip is a ball and socket joint. So it does 6 different movements. So it does hip flexion and extension. It does ab and adduction, and it does internal and external rotation. Remember, external rotation is the same as lateral rotation, where the hip is going outwards. Well, we spoke about the muscles that do this action. Whenever you hear the gemelli twins, that's an external rotation. Those are external rotators. The obturator twins, because there's 2 of those, that one's a hip external rotator. The quadratus femoris, all right, that's a hip external rotator. But the 3 that you need to know 3 external rotators. The piriformis, it's that small muscle that basically is over the sciatic nerve. That's one of the muscles that you are going to need to know, the piriformis. The sartorius, that's that long strap-like muscle that's on the superficial anterior side, right above the quadriceps muscle. Remember, the sartorius has an origin at the ASIS, and this is the 3rd muscle that inserts into the pes anserine with the gracilis and the semitendinosus. And finally, the last external rotator you need to know is the gluteus maximus. So the ones you need to know, you definitely need to know that gluteus maximus, sartorius, piriformis. Those are the 3 main hip rotators. The 3 main hip rotators. Hold on a second. Let me just roll this down. Hip flexors, hip internal rotators. That was interesting. What happened here? Sorry. And my sheet doesn't have my hip flexors. Okay, but I got it here. All right. The major hip flexors. All right. Let me just write a note to myself to write that on this sheet here. Type it in. Add hip flexors and internal rotators on. Good. Add hip flexors. Okay. Beautiful. So the major hip flexors, first of all, the iliopsoas, that's that muscle, that's the combined muscle between the psoas major and the iliacus. The iliopsoas is the strongest hip flexor in the body. Boom, strongest. Another flexor of the hip is the rectus femoris. Remember, the rectus femoris is one of the quadriceps muscles. One of the 4 muscles of the quadriceps. You got rectus femoris, and you have the 3 vastus muscles. Rectus femoris has its origin at the AIIS. Remember, sartorius is at ASIS. And rectus femoris inserts into the quadricep tendon, creating the patellar ligament that goes into the tibial tuberosity on the tibia. 3rd hip flexor is the sartorius. Again, that large strap-like muscle, the talar muscle. Okay, so sartorius has a lot of functions. And finally, the TFL, the tensor fascia lata, even though it's a small muscle on the lateral side, it has a major movement in hip flexion. The internal rotators. So we spoke about those external rotators, you know, like, let me just kind of go over them. So the external rotators like gluteus max and sartorius and piriformis. Well, the internal rotators are the other glute muscles, glute medius and glute minimus, and also the TFL. The TFL is the other. So the tensor fascia lata is the other internal rotator of the hip. All right. As we go down the leg a little bit, we go to the knee. Now, the knee seems to only have two movements, flexion and extension, but it actually has a rotation movement. Now, I'm not going to ask you about the muscles of rotation on the knee. We'll go over that in kinesiology. All right, but I need you to know the muscles that perform knee extension and knee flexion. The knee extensors, the muscles that straighten out the knee, well, that's the quadricep group. The quadricep group in the front does knee extension. Okay, so the rectus femoris and the three vastus muscles, vastus lateralis, vastus medialis, and vastus intermedius. Now, real quick, remember, rectus femoris is the only one of those muscles that have an action at the hip, because rectus femoris has an origin at the AIIS. The three vastus muscles have origins on the femur itself. It does not cross the hip. It only crosses the knee to perform knee extension. There are many knee flexors, many knee flexors. Let's get the main ones first. So the top three are the hamstring muscles. Remember, the hamstrings are the major knee flexors: semimembranosus, semitendinosus, and biceps femoris. The big calf muscle, the gastrocnemius, is a main knee flexor because it has its origin on the femoral condyles of the femur. So that's a very important knee flexor. Tricky. That's another one of those two joint muscles where it crosses the knee to help perform knee flexion, and it crosses the ankle to perform plantar flexion. The gracilis and the sartorius. Now, if you remember the pes anserine, you will know that all the muscles that are located on the pes anserine perform knee flexion: semitendinosus, gracilis, and sartorius. And finally, the popliteus muscle. It's that small muscle, but remember, that's the muscle that is the unlocking of knee extensors, of the knee extension position. All right, it's the popliteus muscle. Okay, so those are the main knee flexors of the body. Like I said, the shoulder is a very important part of the body that we as PTAs work on. I need you guys to know the rotator cuff muscles. In almost every one of my videos where we talked about muscles, whenever we got to the shoulder, I keep on saying it. You have got to know these muscles cold. You must. So the rotator cuff muscles, again, their job is to keep the humeral head in the glenoid fossa. They're known as the sits muscle, and it's taken from the first letter of each of the four muscles. So the rotator cuff muscles are supraspinatus, infraspinatus, teres minor, and the subscapularis. Those are the 4 rotator cuffs. You must know them. You must know everything about them. Everything. No kidding. No joke on that. All right. Now, like I said, there's certain muscles work together to perform motions at the scapula. And we're going to go over those, what we call force couples when we get to kinesiology. So the scapula does a lot of motions. The scapula can be depressed. It can be brought down. It can go in a downward rotation where, let's say my thumb is the glenoid fossa. Downward rotation would be like this, and upward rotation would be like that. So you got depression, downward rotation, upward rotation. You got elevation of the scapula. You have retraction where the scapula kind of goes forward. And then you have protraction where the scapula comes back to neutral. So you got protraction and retraction also. I didn't put the protractors. Oh. Retractors, but I didn't put protractors. Oh, that's not good. Okay. Well, I'll write that down and I will put that on there, but I will also talk about the protractors. All right. So the scapular depressors, the ones that bring the scapula downwards, that's the lower trap, the Latissimus Dorsi, and the Pectoralis Minor. Now, again, a lot of people forget about the Latissimus Dorsi, all right? Because everybody thinks, oh, Latissimus Dorsi is this big back muscle. Everybody forgets that, well, that Latissimus Dorsi inserts into the bicipital groove, so it's a major extensor of the shoulder. We'll get to that. But remember, one of its origin points of the Latissimus Dorsi is the inferior angle. So the Latissimus Dorsi assists with depression of the scapula. Lower trapezius makes sense. Lower trapezius has its insertion onto the spine of the scapula, so it pulls it down. Latissimus dorsi, it does make sense. It's on the inferior angle, pulls down the scapula. Pectoralis minor, though, is on the front. It's on the coracoid process. All right, so when it contracts, it actually stabilizes the scapula and helps the other 2 muscles do that depression. Scapula downward rotation. All right. So again, what you're going to learn in kinesiology is that these 3 muscles do different actions, but when they work together as what we call a force couple, they perform this rotation, whether it's downward or upwards. So the 3 muscles that perform a downward rotation of the scapula is the rhomboids. Remember, the rhomboids help with retraction of the scapula, so bringing the scapula back. The levator scapula helps with elevation of the scapula. Remember, levator scapula comes from C1 through C4 and attaches into the superior angle. And the pectoralis minor. The pectoralis minor is a stabilizer. It helps maintain the position of the scapula. But when all 3 of those muscles work, it brings the scapula in a downward rotated motion. Get those. The scapula can also elevate. And what I mean by that is, so the scapula can depress, go downwards, but it can also go upwards. The levator scapula makes sense. C1 through C4 and attaches to the superior angle. The rhomboids bring the scapula forward brings the scapula backwards in retraction, my apologies. okay? And the lower trapezius. Again, the lower trapezius doesn't make sense, but when they work together, and I'm going to show you in kinesiology how they work together to perform scapular elevation. The scapular retractors. So the retractors bring the scapula back to its neutral position. So let me real quick go over the protractors of the scapula. So the major protractor of the scapula, the movement that creates the punch move, all right, where the scapula comes forward, protraction, is the serratus anterior. The serratus anterior is the main protractor of the body. The pectoralis minor is a secondary protractor. So the protractors are the serratus anterior and the pectoralis minor. So that brings the scapula forward. The muscles that bring it back are the rhomboids. Remember those rhomboids that going in a diagonal? They come from the vertebra and attach to the medial border, as well as the middle trapezius. The middle trapezius comes across. All right, the middle trapezius has an origin at the acromion process. Goes from the acromion process to the middle, to the medial border of the scapula. So scapular retractors bring the scapula back from a protracted position. The final movement of the scapula is scapula upward rotation. So again, these three muscles work together to rotate the scapula in an upward fashion. And that upward rotation is very, very important. And we'll talk about it when we're discussing movement of the shoulder. The three muscles that work together in upward rotation is the serratus anterior. Remember I just said serratus anterior is the body's main protractor. The upper trapezius. The upper trapezius is an elevator of the scapula. And the lower trapezius. Those three muscles work together to help upwardly rotate the scapula. All right. Now let's get to the shoulder. All right. So again, the shoulder, just like the hip, is a ball and socket joint. It has basically 6 major motions. It has another 2 motions, the horizontal abduction and the horizontal adduction. I'm not going to go through the muscles of those 2. All right. We kind of know some of them already. When we talk about the delts. All right, but we're going to talk about the main 6 motions. So shoulder abduction, where we bring the arm away from our body. Abduction, meaning away from our body. There are 2 muscles that perform that action. The supraspinatus and the middle deltoid. Let's remember when I spoke about the supraspinatus performs the first 30 degrees of movement of shoulder abduction. And then the middle deltoid takes over after that. So again, the 2 major the 2 major movers of shoulder abduction is supraspinatus, the first 30 degrees, and the middle deltoid. Shoulder adductors. So after I abduct, I bring the arm back, and that's known as adduction. I'm adding to the body. For shoulder adduction, there are 3 main muscles that perform that action. Teres Minor, Latissimus Dorsi, and Pectoralis Major. Let's look at them. Teres Major has its origin on the scapula near the inferior angle. So it's actually a back muscle. but it inserts and it comes around to the front and it inserts onto the lesser trochan, the lesser tubercle of the humerus. So when it contracts, it pulls the humerus inwards towards the body. Latissimus dorsi is also a really large back muscle. It has its origin on the sacrum, on the pelvis, on the lower four ribs, on the inferior angle of the scapula. This is a large back muscle, but it inserts into the bicipital groove of the humerus. So it inserts on the front of the humerus. When it contracts and comes closer to each other, Latissimus dorsi also pulls the humerus inwards towards the body, assisting with adduction. Pec major. Pec major comes from the sternum and the clavicle. That's where the origin is. But just like latissimus, pec major inserts into the bicipital groove. Hence, when those muscles contract, it pulls the humerus inwards towards the body. Hence, pec major also does shoulder adduction. Again, you guys got to start to picture the muscles where they are, and that will help you on what they do and what their job is. Sometimes you're not going to remember every single one of these motions. So you're going to have to know where it's located, what its origin and insertion is, and that will help you. Here's the thing. When we're talking about adduction of the shoulder, it kind of doesn't make sense that Teres Major and Latissimus do adduction. But because I know that they insert on the anterior side of the humerus, and when they contract, they're coming together, which means the pull is going to be inwards. So again, the shoulder adductors, we're talking about Teres Major, Latissimus dorsi, and the pec major. The shoulder extensors. All right, the main shoulder extensor is the Latissimus dorsi. The main one is Latissimus dorsi. The triceps brachii is a very important shoulder extensor. Remember, shoulder extension is the bringing back of the shoulder. Shoulder flexion is going forward. Shoulder extension is bringing it backwards. You might see it as called as hyperextension, but I want you to just know it as extension. Okay, we'll talk about hyperextension in kinesiology. The third real important extensor of the shoulder is the posterior deltoid. Posterior deltoid, because its origin is on the spine of the scapula, and when it contracts, it pulls the arm backwards. Teres Major and Pectoralis Major are two of the minor muscles that do extension, but they need to be on the list because they do a lot of work in shoulder extension. So those are the extensors of the shoulder. Now, a group of muscles that we go over an awful lot is the shoulder flexors. All right, the shoulder flexors. This is a very important group of muscles that you guys need to know. It is one of the, again, another acronym that I use, kind of like BBB for the elbow flexors. Shoulder flex, for the elbow flexors, for the shoulder flexors, I use ABC plus pec major. What that means, the A is the anterior deltoid. The B is the biceps brachii. The C is the coracobrachialis and pectoralis major. Those are the four muscles that perform shoulder flexion. Very important. Please remember this. Coracobrachialis. It's telling you what its origin and insertion is. It comes from, its origin is on the coracoid process of the scapula, that little finger projection. And it inserts onto the humerus, onto the mid portion of the humerus. Please know this. Coracobrachialis has no action at the elbow. Its only action is at the shoulder. So shoulder flexors. We have rotations at the shoulder. We have internal, also known as medial, and we have external, also known as lateral. The external rotators of the shoulder, the muscles that move the shoulder outwards, move it laterally, are the Teres Minor, the infraspinatus, and the posterior deltoid. Let's look at those muscles and where they're coming from. Teres Minor is coming from the lateral border of the scapula, and it inserts into the greater tubercle of the humerus. Infraspinatus is on the posterior side of the scapula, and it's inferior to the spine of the scapula in the infraspinous fossa, and it too inserts into the greater tubercle of the humerus. The posterior deltoid is above those muscles, is above them. All right, it's superior to both Teres Minor and infraspinatus. It's on the posterior side. Its origin is on the spine of the scapula, and it inserts into the deltoid tuberosity. So those three muscles, each of them perform shoulder lateral or external rotation. The internal rotators of the shoulder, right? There's a few more of those. So that rotates the shoulder inwards or medially. Teres Major. Remember, Teres Major is coming from the lateral border of the scapula, but it inserts into the lesser tubercle on the front, and it does internal rotation. Pectoralis Major is on the front. It's on the anterior part. It inserts into the bicipital groove. It does internal rotation. Subscapularis, all right? It's the final S in the sits. It's the rotator cuff muscle. Subscapularis is on the anterior side of the scapula. It too inserts into the lesser tubercle, and subscapularis does internal rotation. Latissimus Dorsi, that big muscle in the back, but it inserts into the bicipital groove, which is on the front, on the anterior side. That is, again, another muscle. Teres Major and Latissimus are two muscles that are forgotten when we're performing internal rotation of the shoulder. The final muscle that does internal rotation of the shoulder is the anterior deltoid. Anterior deltoid has its origin on the lateral third of the clavicle. So it's coming from here. So it's on the anterior side, and it inserts into the deltoid tuberosity. So when it contracts, it brings the humerus inwards. Hence, it does shoulder internal rotation. Go down to the wrist, the last part. So at the wrist, we have wrist flexion, we have wrist extension, we have wrist radial and ulnar deviation. With the flexors and extensors and the radial deviators, I'm going to want you to know the primary movers of these motions. So wrist extension, where the wrist is brought up like this. All right, it's brought up like this. So you'll notice on the left-hand side, I have primary muscles, and on the secondary, I have other muscles. Now, please notice this. The primary muscles are the muscles that have no actions at the fingers, at the digits, and the secondary muscles has an action at the wrist. It does extension, but they have an action at the digit, at the fingers. So the secondary muscles are two joint muscles. All right. It extends the wrist and it can extend the fingers. So the muscles that I want you to know are the carpes. So the primary wrist extensors, extensor carpi radialis longus. Extensor carpi radialis longus has an insertion at the second metacarpal. Extensor carpi radialis brevis has an insertion on the third metacarpal. And extensor carpi ulnaris, which is on the ulnar side, on the pinky side, has an insertion on the fifth metatarsal. Since these are extensors, they come from the common extensor tendon, which is the lateral epicondyle of the humerus. Those are the primary extensors of the wrist. Now, these other four muscles cross the wrist and go to the fingers. Extensor digitorum goes to 2 through 5. Extensor indices extends the index. Extensor digiti minimi extends the pinky. And extensor pollicis longus, so this is flexion, it extends the thumb, brings it back. So again, the main wrist extensors that I want you to know: extensor carpi radialis longus, extensor carpi radialis brevis. Remember, longus goes to the second metacarpal, brevis goes to the third, and extensor carpi ulnaris goes to the fifth metacarpal. The wrist flexors. So the wrist flexors come up the bottom side. When we're talking about wrist flexors, they originate at the medial epicondyle. The medial epicondyle is the common flexor tendon. Okay? So the main flexors of the wrist that you're going to need to know are, again, the ones on the left, the primary ones. Only act at the wrist. Flexor carpi radialis. Flexor carpi radialis inserts into the second metacarpal. Flexor carpi ulnaris. Remember, so radialis is on the thumb side. It goes to the second metacarpal. Flexor carpi ulnaris is on the ulnar side. It goes to the fifth metacarpal. And palmaris longus, remember that muscle that that some of us might not have. Like I have it on my left, but I don't have it on my right. Palmaris longus flexes the wrist. It attaches to the palmar aponeurosis right in the middle there. So those are the three wrist flexors that I'm going to want you to know. Remember, so the ones that go to the fingers, don't forget that they also have an action. In order to get to the fingers, they've got to pass the wrist. So they too have action at the wrist with flexion. So flexor digitorum superficialis. Remember, that's the muscle that goes to the PIP, goes to the middle part of the finger and allows the finger to go like this. Flexor digitorum profundus. Well, that's the muscle that inserts into the distal phalange. And it is the only muscle, 2 through 5, that allows you to flex the distal digit. All right, so profundus allows you to do this. Superficialis allows you to do this. Superficialis cannot do the distal digit. Flexor pollicis longus is the muscle that flexes the thumb. Flexes the thumb. So know the primary wrist flexors. Flexor carpi radialis, flexor carpi ulnaris, and palmaris longus. going to go longer than I expected. Sorry about that, guys. All right. Wrist radial deviators. I'm going to want you to know the wrist radial deviators on the left. So radial deviation is where the wrist tilts to the thumb side, tilts towards the radius bone. There are two main muscles that perform radial deviation: extensor carpi radialis longus and extensor carpi radialis brevis. And we spoke about those two. Remember, they insert onto the second and third metacarpal, which forces it towards the radial side. Hence, extensor carpi radialis longus and extensor carpi radialis brevis does radial deviation. Now, you'll see a lot of these other muscles doing it too. And you'll notice there's a lot of thumb muscles. The thumb is here. Here's the thumb muscle. Here's the thumb going towards the radial side. So, extensor pollicis longus, extensor pollicis brevis, flexor pollicis longus, abductor pollicis longus. Those four muscles help with radial deviation. Again, the primary muscles you need to know: extensor carpi radialis longus and brevis. But some of the secondary muscles you need to know also. But so think about it. If it's on the radial side, the thumb is going to have a big important part. Look at that sheet. You could see 4 of the muscles are thumb muscles. The other muscle is flexor carpi radialis. Again, another muscle that comes off onto the second metacarpal there on the radial side. When we're talking about ulnar deviation, with ulnar deviation, we're talking about muscles that are going to be on the pinky side, on the ulnar side, to tilt the wrist towards that side. Well, there's only 2 that you're going to need to know. And they sound the same. There's just a different motion: extensor carpi ulnaris and flexor carpi ulnaris. Those are the ulnar deviators that I need you to know. Now, a couple of other things that I'm going to add to this list that I was looking at today that I want to add to the list. When we're talking about the rotators of the trunk, all right? When we're talking about the rotators of the trunk, we're talking about the obliques, the internal oblique and the external oblique. So let's remember their jobs. The internal oblique rotates the body to the ipsilateral side, or the same side, and the external oblique turns the body to the contralateral side, or the opposite side. Now, whenever you rotate, it'll be both of those muscles working together. So, in my example, if you rotate your trunk to the right, the internal oblique, the right internal oblique will turn to the right, and the left external oblique will turn to the right. Remember, internal oblique turns to the same side, external oblique turns to the opposite side. And I'm going to add all these on. In between the ribs, there are 2 sets of muscles. You have the external intercostals and you have the internal intercostals. I want you to know their functions, and they both help with breathing. So, external intercostals, it helps with inhalation, EI. External, inhalation. Internal, exhalation, IE. So when I inhale, my external intercostals are working, and when I exhale, my internal intercostals are working. So very important for you to understand that. Let me give you some information again on the carpal tunnel. The carpal tunnel is the space in the wrist between the carpal bones and the piece of tissue that crosses over it, known as the flexor retinaculum. In that tunnel, you have the flexor tendons and the median nerve that go through. The disease process is known as carpal tunnel syndrome. And this carpal tunnel syndrome is caused by prolonged, repetitive finger and wrist motions. So think of the typist. They always wear a brace on their wrist because they're moving their fingers and keeping their wrist in a really bad position for long periods of time. And what that does, it causes the tissue in the tunnel to become inflamed and get all of the characteristics of inflammation. Remember, the characteristics of inflammation is redness, heat, pain, and swelling. Those are the four characteristics. And because of those characteristics, there is a fifth characteristic, which is a decrease in range of motion. So whenever you have characteristics of inflammation, it's going to cause pain, okay? And it could cause the body part to have decreased range of motion. What happens with this carpal tunnel is because this tunnel is very small, the retinaculum actually puts pressure onto the median nerve. And what happens, because it's a nerve, if you think about it, think you got your funny bone over here, all right, on your right near your lateral epicondyle. And if you push into it, you can actually cause numbness into your hand and elbow. So don't do it, but we'll do it in kinesiology. But the same thing occurs in the carpal tunnel. When the median nerve, when there's pressure put on the median nerve, there is tingling and numbness and pain that can go into the hand that actually makes the hand very weak. Also, what can happen is that tingling and numbness and pain can go up into the arm and into the shoulder. So that's what occurs with carpal tunnel. Now, the treatment for it, well, we use some anti-inflammatory drugs, maybe some of the anti-inflammatory aspirin. There's Toradol, to try to calm down the swelling. We will brace the wrist. We'll immobilize it so that it's not moving that much. Remember, what causes it is repetitive motion, okay, and poor positioning. Well, if we can stop that, then we can decrease the symptoms. If we can't do anything in physical therapy, we also use ice too. Ice decreases swelling. It also decreases pain. And that's one of the things we do a lot. We use ice to decrease that swelling and decrease the pain using the gate theory, which is pretty advanced stuff. And you'll learn about that in future classes. So the surgery that they would do is it would actually remove the retinaculum, that tissue over the tunnel, in order to relieve the pressure. So if it has to happen, it has to happen. But they'll try conservative methods, which we are as physical therapy, to try to alleviate the problem. I want to talk about the Erector Spinae muscle. Remember, this is a back extensor muscle. And when we're looking at the spine, so here's the spine right here. Here's my version of the spine. You have a set of muscles that are very, very close to the spine. Well, those muscles that are close to the spine is the spinalis muscle. Spinalis. You can't really, right? Spinalis. Then there's a second set of muscles. And this is the longissimus muscle in the middle. Longissimus. Right? So that's the L right there. And fine, so and here's the ribs. So we got ribs right over here. All right, you got ribs right over here. The muscle that's closest to the ribs is known as the iliocostalis muscle. The iliocostalis muscle. So this is the eye. So the Erector Spinae, which is a major back extensor, is made up of three muscles. The spinalis, which is closest to the spine, remember, spine spinalis. The longissimus, which is the middle muscle, and the iliocostalis, which is the most lateral muscle, and it sits closest to the ribs. Remember, costo means ribs. All right, so we'll take that off. We're almost done, folks. A couple of more things I just want to go over real quick. Let's talk about the pes anserine. I've talked about it a few times today. Remember where it's located. It's located on the tibia. It's located close to the tibial tuberosity. If I asked you where it was, you would tell me it's on the anterior medial proximal portion of the tibia. Anterior medial proximal. The three muscles that insert into the pes anserine is the semitendinosus, one of the hamstrings, the gracilis muscle, and the sartorius muscle. Those are the three muscles that insert into the pes anserine. Now, we haven't talked much about ligaments. I'm going to want you to understand 4 ligaments in the knee. All right, 4 ligaments in the knee. Now, it is part of the muscle packet that I gave you guys, this lecture. So this is what I'm going to need you to know. The medial collateral ligament, the MCL, medial, so it's on the inside. The medial collateral ligament stabilizes the inner knee. The lateral collateral ligament, the LCL, stabilizes the outer knee. Kind of makes sense so far, right? Okay. The anterior cruciate ligament, the ACL. The ACL is one of the most injured ligaments in the body. It's ACL injury is what got me into this field, right? Because in 1991, I tore my knee up. I tore my ACL, I tore my medial meniscus, and I tore my medial collateral ligament. And I went through a year's worth of rehab. And I fell in love with it. And I still love it to this day. And my knee is doing good, except for the arthritis. It's hurting lately. Maybe it's because of the cold. The job of the ACL is to keep the tibia from moving forward. Is to keep the tibia from moving forward. So the ACL and the PCL is all about the tibia. Okay? The ACL keeps it moving forward. The PCL, the posterior cruciate ligament, prevents the tibia from moving backwards or in the posterior direction. That's what I need you to know about the ligaments of the knee. All righty. Let me clear this. Like I said, I'll be giving you guys this movement packet most likely on the Thursday of week 1, because that's when we're going to be actually starting the muscles right there. Ashley, do you have any questions? Did I put you to sleep?
No, done. All good.
Again, is a lot of information. Take it, break it down. Now what I want you to do is now you take those muscle cards those flashcards, and you break them up into body parts. And you say, okay, these are the muscles of the shoulder that I want to work on. These are the muscles of the elbow I want to work on. These are the muscles of the wrist. All right. And if you can put them together in that way off of this sheet, now, when you look at this video, you can actually put the cards in those correct places. And then you can study them like that, because they're actually in an area that actually makes sense. What are the shoulder flexors? Okay, anterior, the deltoid, the biceps brachii, the coracobrachialis, and things like that. It's going to be a really good way for you to study. And then you throw in the the innervations that we spoke of yesterday. Then we're getting some of the hardest parts of the muscle. All righty?
Sounds good.
Okay. You have a wonderful weekend. Please stay healthy. Please feel better.
Thank you.
All right. I want to know how you're doing. I want to make sure you're okay. Okay. That's important. Okay.
Yep. Sounds
All right.
good.
So I'm going to work on sending this out now. And I'll see you Monday. Is 1 o'clock good for you, or 2?
Honestly, the next week I'm pretty open. Don't have, if I am so-called working, I'm just dog walking right now.
Okay.
For the being, so I can go on my phone.
All right. I think I'm going to just change the time to 1 o'clock and kind of get them over with next week. Like I said, I'm kind of just revert back and kind of review the muscles, the bones and the muscles next week. So I think we've hit a lot of information. So take your time, don't overstudy, don't burn yourself out. All right. And just get better. Okay.
Will do.
All right.